I think that's exactly spot on, as I think as all of you have talked about, is that there are a couple big issues here that I think that our audience really needs to understand, is that there is testing for potential treatment of the patient who has been diagnosed, usually the ones with a higher grade, more aggressive, by definition, histopathologic diagnosis of prostate cancer, how that testing might affect their future therapies, or, as you said, Mike, testing in order to give better family counseling. Who's at risk down the road, whether, for their siblings? And I think it brings up the whole question is, and I don't, I'd like to just ask the panel is, when do you believe should you start testing? Should you start it at diagnosis? Is it for everybody with prostate cancer, regardless if they're low risk, very low risk, low, intermediate, or high risk? Or should we be testing at the time when they start to progress to CRPC? I mean, Neal, what are your thoughts on that?
Well, it's a very good question. It's a very complicated answer. It's not simple at all. One of the things that clearly is now very high on my radar is I have a young man, or even could be older, and young, old is very subjective, right? The older I get, the younger that chronologic age becomes. But having said that, when there is a demonstrable evidence of mortality from prostate cancer and these other important hereditary solid tumors such as breast, ovarian, GI, pancreas, and there's an uncle, father, brothers, then I'm really now telling my patients to go and get genetic testing for their children and their nieces and nephews. There are many companies that are out there that will do this genetic testing. It's easy to do. You get it from saliva, you can get it from blood. And most of them are offering some forms of 800 call-in numbers and getting information. Many of the genetic counselors who are out there, and it takes time, as Evan said, this is the challenge. It takes expertise and it takes time. And the challenge is in the country, in the United States today, my understanding, there's only about 3,000 nationally. And so at many of our best academic institutions, there's a several-month waiting list to get in, even in these places of higher learning and more sophistication. In most of the rest of the community, you might have to drive hours to get to even find someone. So I'm not giving you a very quick and direct answer because I'm working through this. One of the things that I'm really hopeful is that these companies, and there's several of them out there, as well as the companies that have new therapies that could use this genetic testing as a compendium diagnostic so that we could better personalize our treatment decision, work together with all of us for educational purposes. We really have to lift the threshold of what we're doing. It's very, very low right now.
Yeah, I think education is a key part of it, and whether we can have videos or you have to meet with a genetic counselor, I think a lot of that's coming forward, but there's a step forward. I mean, not only do you have direct patient marketing for these assays on TV, your doctor has particular tests. Some are paid for by insurance, others are out of pocket. So there's those issues that you want to bring up with, and then there's a whole nother list that aren't just these things about hereditary, but sort of are more panels of genes that tell you whether you're going to recur, you're not going to recur, you're going to have metastasis, these sorts of ththings. So patients need to sort of know what test I'm getting and what does it mean to me. This is just, I have a risk, my family has a risk, where there's other tests that the urologists use more frequently to predict whether they should go on active surveillance or whether they should get combination radiation therapy or other types of approaches.
I think it's pretty clear, like I think all of you have stated, is that we have to move beyond this notion that when we take a good history, and I think unfortunately it's a lost art, that we need to do a better job of going to the next level, again, asking about all these other tumors that we know historically, as you said, Neal, that urologists, we've been relatively naive about not considering them into the whole play of how this affects prostate cancer. The breast cancer patients, the ovarian cancers, the pancreatics, GI tumors, Lynch syndromes, those types of things. I think, we need to do a better job, and I think it can be done. Within this day and age of electronic health records, it could probably be done really simply through a kiosk or online, and as we build these trees out. I think what you were saying, Mike, also bears again, I think reiteration, is that what we're seeing now is commercially available tests that people can call up and get for $99, and those are different types of tests than some of the panels that Neal, you were alluding to, of companies that are out there specifically looking at a panel of genes that are specifically looking at some very distinct gene mutations, which again I think then the whole complexity of once all that comes back. I know Michigan has recently started up a dedicated prostate genetic counseling center. Are you guys thinking about doing that, Evan, at Washington? Or?
I'm sorry, we started the first one.
There we go.
There
we go.
Michigan's right after us, but I'll be straight. And Colin Pritchard, the New England Journal paper that showed 12% of patients with metastatic prostate cancer have germline alterations was from our center, with Colin Pritchard's paper. And Heather Chang is a wonderful young faculty member in our center who's focused on genetics, working closely with Mary Claire King as well. And so she's started a high-risk genetics clinic. So I think the dilemma for our center is a little bit easier because one could argue, if you ask a trained geneticist, when should you screen somebody, they would tell you that if the incidence is over 10%, you should take a look. And we're looking at, 11.8, almost 12%. One could argue that maybe we should be testing everyone with metastatic prostate cancer. Now again, reiterating the fact we don't have enough genetic counselors, I don't have the training, but Dr. Heather Chang, who runs our high-risk genetics clinic, also has a genetic counselor in that clinic. So when I see patients who have metastatic prostate cancer, especially those who have an interesting family history or an interesting personal history, I send them to Dr. Chang's clinic, and she does the counseling with the genetic counselor. They decide if it's proper to do testing or not. And she's doing research studies too, and family studies as well. Because one of the things we haven't talked about yet is, well, what if you find something that we know about, like BRCA2 or ATM or something like that? What if you find something that we don't know about yet? There's these variants of unknown significance or uncertain significance. These things may pan out to be something in the future. So we find all these genetic alterations, we don't know what to do with them. That's when you really need a genetic counselor, somebody to do the adequate follow-up with that as time goes on. So again, I think it's not a trivial issue that we can just all run off and do this on our own in our own clinic and test everyone. We really have to do it right. And so yeah, we have a high-risk genetics clinic.
So at Hopkins, we have sort of a tumor board for the physicians to go to. If someone's got these testing or we've ordered the testing and you need someone to help you interpret it so that you can sort of think about, as Evan said, some of these variants, what do they have meaning, or this predicts for gastric cancer, what do you tell them about, we don't take people's stomach out just because they have a risk for it. How do we follow that person? So there's information that I need to go back and educate my patient. So I can go, there's counselors, there's people who really know genetics who can look through these panels and sort of say, not worrisome, yes worrisome.
Maybe worrisome.
And figure out what you should really be communicating to the patient.
But one other thing, though, about this, Raoul, that's important is that we're leaving out is, and part of this conference was, so there's clearly all the downstream applications, which is really, there's no perfect algorithm for it. But the thing that we haven't even mentioned as well is patient choice. There are many patients who don't want to have this information. And then what do you do if you obtain this information, the patient doesn't want the information or doesn't choose to share the information with his or her spouse and or children? There's some very interesting and challenging ethical issues. People leave, people move, you're holding on to this information. So we're really, again, we're at the beginning of this beginning, and so that was really the wonderful thing about Jefferson putting on this conference and trying to get some level of consensus from a lot of folks who were perceived as, as key opinion leaders in various fields. And so it was really great to see that. The manuscript has been submitted, and hopefully that'll come out in the near term. And folks watching today could read through that, some of these questions that were asked. And frankly, there was not a tremendous amount of consensus amongst a lot of experts, getting back to the challenge of where we are.
I have to comment. I think that is exactly the biggest challenge that we face, because naturally, if you present it to a patient that, hey, I can get this panel of tests, and if I find an abnormality in this gene, and maybe you have a 12%, maybe even up to a 25% if you add in the somatic alteration risk of having one of these, DNA repair deficiency gene abnormalities, this could help your treatment down the road. This may predict response to a PARP inhibitor, to platinum chemotherapy, et cetera. What patient's going to say, well, no, I don't want to do this test? So you have to take the time to tell them that there could be implications for your family. Maybe you want to know, maybe you don't want to know. There could be implications downstream for insurance. I mean, who knows what's going to happen with pre-existing conditions, right? So again, once you actually take the time, I've started to have patients refuse to do the testing. But if you just say, oh, this could affect your treatment down the road, of course they're going to say, yeah, I want to know. You got to do the whole thing. And we're really not properly trained to do the whole thing, which is why there is no consensus, because we want to do it, but we all know that we don't really have
and we're
all that
time
training.
Constrained. Everyone's time constrained. So.
And the final thing is we still don't know what to do with it. Would we change our therapy? Would we do something different? Or are we just on alert? So those are the sorts of things that we have to figure out as well.
That's why I even said maybe predictive. We still don't know. We're doing the clinical studies right now. We don't know that they're definitive predictive biomarkers.
Isn't that the term that they use, the genetics people? They call these people previvors. These are people who are predestined to, if you will, to potentially, based upon their genetic testing, to have something down the road, but they haven't started down the process. It's not been diagnosed. And again, for some people, that just might be too much from an emotional standpoint, from a psychological standpoint. I mean, that's a heavy load. Right. That's a heavy load.